Good afternoon, everybody. Welcome to our September 2023 edition of the Sentinel Innovation and Methods Seminar Series. My name is Judy Mara. I'm an assistant professor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute, and I sit in the Sentinel Operations Center. The US FDA's Sentinel system helps us to address questions related to the safety and the effectiveness of marketed medical products. The Sentinel Innovation Center focuses on developing innovative methods to further advance Sentinel by leveraging new data sources, building new tools, and enhancing real-world evidence capabilities through advanced analytics. Where I work at the Sentinel Operations Center focuses on supporting the FDA in the use of the Sentinel Common Data Model and the associated modular programs to gather evidence to support regulatory decision-making. The Sentinel Operations Center maintains the FDA's Active Risk Identification and Analysis, or ARIA system. Together, the Innovation Center and the Operations Center has launched this webinar series to engage experts and innovators in key areas related to the Innovation Center's master plan and the Operations Center's methods work. And with that, I'm pleased to announce today's speaker, Dr. Walsh. Dr. Walsh is an associate professor of biomedical informatics, medicine, and psychiatry at the Vanderbilt University Medical Center. He's an internist. He received his medical degree at the University of Chicago and completed his residency in internal medicine at Columbia University Medical Center. He received a degree in biomedical informatics at Columbia University and joined the faculty at Vanderbilt University Department of Biomedical Informatics, Medicine, and Psychiatry in 2015. His research includes predictive decision support to enable prevention and scaling phenotyping for precision medicine, as well as population health informatics. The title of his presentation today is Scalable Incident Detection via Natural Language Processing and Probabilistic Language Models. Before we get started, I'd like to encourage everyone to make sure that their lines are muted. If you'd like to pose a question, I'd like you to please type it into the Zoom Q&A feature. We're going to answer questions at the end of the session, so don't be alarmed if we aren't answering questions through the middle. And we'll have a great discussion at that point in time, and we've saved plenty of time for discussion. Finally, the slides today will be made available through the Sentinel webpage at our website, www.sentinelinitiative.org, and the recording will be available too. This session is being recorded presently. And without further ado, I will thank Dr. Walsh for joining us and give it over to him to get started today.
Thank you so much for that generous introduction. And thank you everyone who's taken a little time out of your day to join me to hear a bit about some of the work we've done under the umbrella of the Sentinel Innovation Center. So without further ado, I'll get into the meat of the talk. And first, I'd like to get my thanks out of the way early. First, a couple of folks I'd like to acknowledge. So Dr. David Kent, in otolaryngology at Vanderbilt University Medical Center, has helped advise us in some of our work in sleep-related behaviors, which is one of the phenotypes we'll hear about today. He was particularly helpful in this one, and I wanted to make sure I mentioned that. And then Yufei Long, who's a relatively new research analyst on my team, who helped tremendously in helping me get this talk put together. So I want to thank Yufei for that. Of course, I'd like to acknowledge the funding that helped support this work. And to be clear, I have no other relevant disclosures, financial or otherwise, for purposes of our talk. My goal today is to talk to you about methods that we hope are innovative in order to use a technology called natural language processing. That's an algorithmic approach to processing text, free text, the types of notes that doctors might write, or the types of messages we might send to our loved ones. It's all fair game. To use this approach, we'll call NLP throughout most of the talk, to detect clinical events in large-scale health records. That's the first main objective of my talk. My second main objective is to describe whether or not this approach, when tested in one clinical area, will generalize or work as well in another clinical area. So you'll hear about how we tested this technology in two key clinical domains. And I'll get into the details of all of this very shortly. First, a bit of background and framing. Why do we care about the idea that NLP might be a tool for scalable phenotyping or scalable signal detection, in this case, clinical event detection in large-scale health records? Well, one example of how that might be useful is based in something that we all are likely familiar with, and this is the idea of post-market safety surveillance. And I am not an expert in this. It's above my pay grade to talk a lot about all the means by which post-market safety surveillance happens, but the idea that a new medication hits the marketplace or a new medical device hits the marketplace, or even more recently, for those of you who think about algorithms as much as I do, a new algorithm or decision support approach hits the marketplace, it's going to have effects at scale across millions of encounters with individuals living their lives across hundreds of clinical settings. There's going to be effects that were harder to detect in smaller trials, even large trials, to be honest with you. So this slide is just from one of many manuscripts in the literature talking about safety-based drug withdrawals when adverse events were detected from medications that were in the marketplace through the really important reporting mechanisms and other mechanisms that Sentinel's expert in terms of tracking safety as these devices, medications, and now algorithms are hitting the marketplace. It's a really key problem. However, like any system, it's not perfect. There are gaps, and sometimes those gaps rely on things like reporting. So for example, if something has to be detected, there needs to be some connection, some intuition that perhaps there's a connection between this new medication and this signal around an adverse event. And so because when something relies not solely on reporting, to be clear, I know there's a lot more than reporting at play here, but as an example, when we rely on reporting, it means someone has to sort of think to do something. So one of the things that motivated our work today is the idea behind a scalable, more automated approach to detecting clinical events that might be concerning in the context of post-market safety surveillance. Adds some significance to that idea. It's the idea that these systems might be running, for example, at a health system like Vanderbilt University Medical Center. And when an algorithm detects signal that rises above the noise, and there's lots of noise in healthcare records, but when we think there might be a signal there, there's something that needs further investigation, algorithms might have a role to play there. So we start to think about systems that inform that type of scalable approach that would hopefully work in context with existing mechanisms of post-market surveillance that are already working well. These systems might detect these kinds of clinical events at scale. We hope they would do so in a timely fashion. And we thought it was important that they're agnostic to whatever computer system happens to be running at the healthcare setting in question. There's a diverse mix of electronic health records out there and vendor-based products and some homegrown products. And we thought tools that were designed to be relatively agnostic to that might be useful too. So with this in mind, we also thought about some of the prior work that we've done in this space that would inform a system like the one that I'm hoping to entice you with a little bit today. We had done some prior work on our team, and you'll see our team's names and the individuals on that team before I'm through. Thinking about another problem that I already said. That's the problem of ascertainment. So my research program and I have spent years thinking about really difficult problems with respect to prevention. And one of the most difficult in healthcare relates to suicidality, suicidal ideation, and preventing suicide attempts. In work that was led by Cosmin Adibihan, who's one of the key work group members for this project I'm talking to you about today, we took natural language processing, ran it at scale across electronic health records at Vanderbilt. And what we hoped to do was to take text-derived data and improve our ability to ascertain or find, is a simpler way to say it, to find signal around really difficult problems like suicidal ideation and suicide attempt that we would want to identify so we could provide better treatment, and to use NLP to improve on standards approaches today. Some of those standard approaches, when you think about health system scale, rely on things like diagnostic codes. And in this plot ahead of you, the diagnostic code here is summarized as ICD. That's a really common one. So combining NLP text-derived features with diagnostic codes performs better than either one alone. We're showing the red line here is showing what text does alone. Combining the two improves this curve. This is a precision rank curve. And precision essentially means, are we finding the signal with minimizing the number of false positives we need to look at? Those are those charts that pop up that may not actually have the signal that we're looking for. Are we finding that signal, again, that signal to noise, so to speak? So a higher curve is better on this plot. And we see that combinations of these approaches outperform either one alone. We're not showing codes here. I will tell you in this paper, and you can read about it, that this approach, the combination, certainly outperforms codes for sure, and also outperforms text alone. So with this motivating work, with this behind us, the key with this approach in this particular paper, which came out in Scientific Reports last year, is that to do this, we looked at an entire healthcare record. So imagine me seeing my physician, and from the moment I first see a physician at Vanderbilt to the very last encounter I've ever had with any physician at Vanderbilt, all of those data were fair game for this particular approach. So what we're not dealing with in this study is time. And I'm going to talk a lot more about what we did with time for the work that I'm going to report today. And that's a really key aspect of what we hope is innovative here, in terms of how we've taken NLP to then detect those clinical events, but critically to do it at a particular time. The standard up to that point had been really to think about this sort of chart level, record level approach. So hopefully that landed for many of you. That time piece ends up being critical in this work. Building on that idea a little bit more is the idea that you could think about looking at the level of an entire record as measuring the prevalence of something. How likely is it, the proportion of a population that might have a thing? But in this case, moving toward a system that might detect events that happen sporadically at points in time is to think more about incidents, or specifically to think about those incident clinical events that might be relevant. So can we describe the amount of new diseases that might occur in certain at-risk people over a period of time versus the proportion of a population that might have something? That distinction ends up being pretty important here. I won't spend a lot more time on it, but we're going to be focusing much more on the left side of the screen here, thinking about those clinical events in time versus the overall proportion of a population. Other challenges in getting to this space. So one key part, and for those of you who are listening in, who may spend time in healthcare records, if you spend any time digging into these data, you know that time ends up being challenging. Another piece of it is interoperability, which I'll comment on in a moment. When we think about time, one challenge in healthcare records is that if I'm seeing a patient in a primary care clinic, at the end of that encounter, I might use a billing code to then say, this is partly describe what I did that day. Well, that code and what it's trying to reflect is going to be reflected in a few other points in that same record. It might come up in the note that I draft. There might be a subsequent charge that follows, or a charge that gets amended when a biller takes a look at that. What that means is there may be multiple signal points for similar identical data that appear at various points in the chart. That can be a good thing. It can add robustness to signal. It can also be a bit confusing. And when you're thinking about algorithmic development, it can also introduce bias. It also can introduce something called leak, which means that you can find evidence of the thing you're looking for because of the way billing works, as opposed to because it's really something that happened clinically for that patient on that day. Critically, healthcare data might be recorded after it happens. It almost always is. So if I write a note for one of my patients, I'm generally not doing it talking to the person, because what I'm trying to do is talk to the person and connect to them, which means those data hit the chart later. That becomes another big challenge when we think about temporality with these types of data. Interoperability is the idea that do we have systems that talk to each other? Open healthcare systems. So Vanderbilt, for example, is an open healthcare system. We welcome our patients going to many different health systems for their care. And, in my primary care practice, I had patients who were very happily seeing specialists from 2 or 3 different health systems. As the primary care doc with that patient, we'd have to coordinate that care and make sure we knew nothing was getting missed and it was all coordinated. But what we didn't have were clear data pipes between each of those 3 systems, so data were automatically being shared. That's still a pretty common problem. There are places that are further ahead in terms of that, and there are states, it's partly a legislative issue. There are states that are further ahead in terms of laws that are supportive of interoperability. The point for our talk today is that because this data sharing doesn't always exist, it means that sometimes care can actually happen for an individual outside a health system and may or may not get documented in another health system. So that challenge becomes really important. There are steps recently to improve this. It's out of scope for me to spend a lot of time on that today. But one of the places where care outside a health system might get documented, even if it occurs someplace else, would be in the note of a person like a primary care doc or a specialist who wants to know what happened to Mr. Smith or Mrs. Jones since the last time they came to the clinic. So notes, what I'm setting us up for here is dealing with time is going to be important. And secondarily, dealing with notes ends up, we think, being important, really for accurate, scalable tools to try to detect clinical events, because codes can be problematic for just a few of the reasons I'm mentioning now. So we set out to ask this question: might this type of NLP approach move beyond understanding the prevalence or proportion of an issue in a population across an entire record to improving event detection clinically? So in our first goal, it was to adapt and test our NLP approach to move from detection across those entire records toward those new distinct events. And then secondarily, a really common step in the informatics work that I do most of the time is that we test and generalize whether it works someplace else. How robust is it to a new clinical problem? There's lots of other ways to test robustness. I'll mention probably in my last slide, but testing it in a new clinical domain is one of the most common first steps. That's what we did here. So first, we need to think about our study cohort. Who are the individuals who we might want to develop and adapt these methods for? So we'll talk about the phenotypes in question, the clinical events in question in a moment. Well, we're going to rely on an electronic health record or EHR repository that's focused on really pushing research. And one that's well known at Vanderbilt is called the research derivative. And it's a really broad, multi-decade repository of electronic health record data is often a starting point for data-driven work like this one. We're looking in this case at adult patients aged over 18 at the time of these encounters. That was one of just a few inclusion criteria here for the first cohort. That's not always our choice. We don't have to choose that. And it's really important to think about different age strata, as well as different backgrounds for individuals for these types of studies. This is the choice we made in this study. And something I say in just about every talk I give, these types of studies involve a lot of choices by the modeling team. And this was one of the ones we made relatively early. And that was based partly because in our prior approach, that's who we were looking at. For lots of reasons I'm going to leave out for now, but I can talk about in Q&A. So we wanted to attest it in a cohort that looks similar to that prior approach to then compare them. That was part of the reason we made that choice. So now let's talk a little bit about the clinical events that we're going to focus on. Now, the first one you'll see is familiar from that background study that I mentioned. We're going to look at similar phenotypes, which we've been spending a lot of time thinking about on our team, and the one in which we'd already published that approach looking at the entire record. So that's suicidal ideation and suicide attempt. Also really relevant because if we imagine that post-market safety surveillance concern, if we imagine a medication hitting the marketplace and potentially having some effect on increasing the incidence of events like those, it would be the kind of thing that might even downstream result in a black box warning. So clinically significant, and not just significant because we care about prevention for our patients, for everyone. We also care about it because it matters in a post-market setting. Secondarily, we picked another phenotype and another clinical area, and that's sleep-related behaviors. We spent lots of discussion talking about, and actually part of our project was to discuss quite a few candidates there, and this is the one we ended up talking about. For those of you who are interested in how we got there, I can again talk about that more in Q&A. But so we're talking sleep-related behaviors, and more granularly, that refers to sleepwalking, sleep eating, sleep driving. We started with parasomnias, which is a fairly broad, heterogeneous label for a lot of different behaviors, and realized through some preliminary work we needed to hone in further. And so this is where we landed, sleep-related behavior. So those are the two clinical events we'll be talking about today. Now, I'm going to slow down and talk a bit about the NLP itself. This is the most methodologically dense slide in the whole talk. I'm going to walk through it slowly, and I'm going to try to give you some intuition for how it works at the end. So for those of you who are interested in NLP and actually practice it, definitely tune in. And there's a nice GitHub repository. So Professor Adi Bihan, who's our fantastic NLP-focused collaborator in this project, is the architect of these methods and helped us adapt them here. So definitely look up his work. And I'll talk about the method now. And again, I'll try to really summarize the intuition near the end before I move to the next slide. So the idea here is the system, this phenotypic retrieval system using NLP, starts with a query, with an event query. So, for example, a phrase we'll often use, and you'll see in the publications on this, is the seed phrase. So something like sleepwalking might be a really good seed phrase. And from that seed phrase, this is using a probabilistic language model, which essentially what it's doing is looking for, it's developing essentially what we call a phenotypic profile. So it's a series of what are called word embeddings, as well as associations in the words that are used, as well as some really well-known probabilistic methods. So word to vec here is shown that's well known to most of you who think about this space would probably recognize that one. To try to essentially take the data in nodes and turn it into a vector, a string of numbers. And those numbers have weights that refer to the embeddings and the associations and the signal around starting from that seed phrase. But this is not a fully automated process. This is one of the things I always like to highlight for this work, and one of the things I really like about it. We start with a seed phrase that we hope is close to the event we're trying to detect. From that seed phrase, we generate an initial list of terms that seem to be loaded. Sometimes those are, what are called unigrams, little single items, and sometimes there could be more than one, n-grams, so more than one word next to each other. And then we look at them. Humans, smart humans, look at them. It's not fully algorithmic. And we sit down with experts like Dr. David Kent, who I mentioned in sleep-related behaviors, and we ask them to look at the list because healthcare records, I've said this already, include a lot of noise. So what happens in that first step is we often generate lists of phrases, for lack of a more pithy word at this point. Those lists of phrases can be refined, and they're refined by people who understand the clinical problem. That ends up being a really important step in this work. So we reformulate and adjust and adapt the query so that it reflects clinically a little bit more what's accurate, a little more of that signal, less of the noise. For example, you can imagine things that might be artifacts of the way documents are written. that seem to be loaded for that seed phrase, but aren't necessarily clinically important. That's a really good thing for us to cross off in our query reformulation step. We apply that reformulation, and you think about that seed phrase as informing what we call that phenotypic profile. So it's essentially, it's not ground truth, right? It's not true north per se, but to a degree, it tells the compass where to point. But that's the thing that's our reference. That's what we're going to compare it to. And then for each new data point, right, whether that's an entire chart, or in our case, we're actually going to be looking at a day of notes, and you'll get to that in a second. We look to see how similar that new vector is from a patient's data, for example, to that phenotypic profile. And if it looks similar as a similarity metric, there's a score that's applied, and that score is higher. And a higher score implies that the event in this case is more likely to be present. So fundamentally, that's the intuition I'm trying to get us to. The idea that we have a phenotypic profile designed from essentially that seed phrase and query reformulation, and saying, okay, this is the signal we're looking for. Oh, and when I look at 1 million charts, these individuals with these really high scores look to be most similar to actually representing that in their text. It's kind of fundamentally, I think, the intuition behind the method. We do the event retrieval step. We apply weighting. So, you'll see TF-IDF is on this slide here. That's something called term frequency, inverse document frequency. It essentially weights terms that appear significantly within, for example, a chart. But if those terms appear in everybody's chart, that IDF piece, they get downweighted. So essentially it's saying, hey, this term comes up a lot for this individual, but it's not represented a lot everywhere else. That means it might be important. We absolutely have to account for something called negation. That is everywhere in healthcare records. So patient denies X. Patient said they did not have Y, right? That negation ends up being critical, and these types of approaches really balk if you don't take that into account. We apply it on a really large corpus of electronic health records, over 200 million notes to start from. Then we look at its relevance. We actually do that step. And then at the end, you end up with a score and a rank. And the rank matters. It's essentially what you imagine it would be. You take all the scores, let's say there's 1,000 of them, and you can rank those. What that can allow you to do is to do certain types of information retrieval focused evaluation, which would be, for example, how well does it work? Something called the top K evaluation, which, let's say you take the top 200 ranked charts, you read each one, and you see how accurate was your algorithm in that case. We're going to do a variant of that approach here. We're actually, and I'll get to that in a moment. But all that to say, the focus here is that phenotypic profile to generate a vector and compare for that patient profile, and then to compare what the patient has in their record to the phenotypic profile for the thing we're looking for. I said that about 3 different times, but if you get that, you get the intuition for the NLP in this study. And the goal here is that the agnostic piece is that any clinical text, really any text, frankly, is fair game. It does not matter what type of note it was. It does not matter what EHR it came out of. It does not matter which setting it was run in. So that's that when we say agnostic, that's really what we mean here. Text input, including metadata if necessary, and then that's probabilistic output. So let's talk about how we handled time. So not quite as dense here, though we spent quite a lot of time discussing how to handle this because there are many options available. And as I said, modeling like this is about choices. So these temporal windows is how we talked about it. It's the idea that if we imagine our original method was NLP applied to an entire chart, we want to hone that in, but how exactly are we going to choose to do that? Our first option that we discussed was thinking about healthcare visit episodes or encounters. Might be a common phrase you hear in this space. So just about every EHR I've worked with has really dense tables that record visits, the start of a visit, the end of a visit, where it happened, who was the provider of record, who actually did something in a healthcare record, because actually pretty tricky to figure out. But those episodes were one level we thought about. In the course of a 5-day admission to the hospital or a 30-minute visit in a clinic, those are both examples of episodes that we might consider wrapping our hands around. One challenge with episodes is actually bounding them can be surprisingly tricky. When a patient comes to an emergency department and is felt to be merit an inpatient admission, and let's say that patient ends up in an intensive care unit, and then they go back to a step-down unit, and then they move to the wards again, and then perhaps they get discharged, or maybe they get discharged to rehab. Complicated example, it does happen. And so where do we start and end that episode? And just finding those data can actually be a little bit tricky, and then distinguishing whether 2 contiguous encounters are related to each other or not is also tricky. All that to say, the point there, it's complicated. And so we thought, okay, simplicity, agnosticism, let's focus on those. So let's think about something simpler. What about time windows? On a given day, in a given 24-hour period, a midnight to a midnight, if we use all the text that hit our system from a midnight to a midnight, as our window. That's a 24-hour window. Might that work? And we talked about lots of other time windows, as you can imagine, too. Combinations of the above, for example, we're thinking about setting or thinking about who wrote the notes. All of those were fair game. At the end of the day, pun not intended, we selected a calendar day, midnight to the next midnight, as the window for event detection. Our goal was that it was useful, relatively simple, and should be, generally speaking, agnostic to an electronic health record. There is a subtlety there for people who work in this space a lot. You might know this already. When things get a timestamp in an electronic health record, that's the time that's in the table for when the thing was supposed to have happened. Doesn't always correlate with when it actually happened. That's a subtlety I'm just going to gloss over, but I will note that we're aware of that one, and we did think about it in the course of this and did some work in that space, but I'm not going to talk much more about it. But because, again, this is a method seminar, I want to emphasize not just the things we think we did that were good choices, I also want to emphasize the potential pitfalls there. So when we come to evaluating our approach, we spent a lot of time thinking about this too. We're going to do a two-phased evaluation. And so I'm going to talk about silver standards and gold standards. Gold standard is likely familiar to many of you. It's in common parlance. It's also a really common phrase in the literature. We evaluated this new approach against the gold standard. Well, a silver standard is the idea that there may be something you want to do more quickly to get a dart on the board, to figure out how an approach might work initially. We use that for twofold purposes here, and I'll mention that in a second. To get a sense of that first cut, how well might it work with a more noise-prone standard, but one that we can apply really quickly. So we're calling that a silver standard here. And we didn't invent that terminology, but for purposes of our talk, I want to make sure that's really clear. The advantage of a silver standard, it's relatively efficient by design, and it's a little less labor intensive to evaluate than a gold standard. We're going to do a gold standard too. You'll hear about that in a second, but we wanted to start with silver for two reasons. The first is we wanted a sense with an approach like this one, an NLP approach like I described, what is the preliminary performance estimate before we do the full study with a gold standard? Secondly, and critically, we didn't just want to do that top K evaluation that I mentioned. So in information retrieval, we might say, okay, well, how well do we work at the top? And now I know if I'm above this particular score, that's where my performance lies. Well, what we cared about here was understanding performance across the score, across every score that was possible for these algorithms. We wanted to have a sense not just of performance at every single score bin, all the way down to zero. We also wanted to have a sense of how wrong we might be as measured by error. So we wanted to set error bars here, and then choose a corpus of notes to hand validate. Corpus is a group of notes, a body of notes. Choose a corpus of notes to hand validate against the gold standard. And we wanted to do it across the spectrum of scores because we felt like we wanted to give some intuition for the system in the future that if it used this NLP approach, you could give the person who was looking at the signal some intuition into how wrong we think we might be. That's a really important thing to try to give people some insight into, and quantifying that uncertainty remains a grand challenge in this kind of work, and not just in NLP, just in modeling in general. So that was the reasoning behind that. I wanted to take a second to emphasize it. It's also why we thought a silver standard was so important here. So now let's talk about the gold standard. We needed to determine the number of encounters for the chart review. I mentioned that part. And we used that performance from our silver standards, which are all diagnostic code based for both clinical events we're looking at, because those are quick to get and they're reasonable to start with, but not necessary, but not sufficient. And we divided our scores from that prelim approach into essentially 5-point intervals. So a score of, for example, 0 to 5, 5 to 10, and so on, all the way up to the top scores. And with this particular method, they tend to land in the low to mid hundreds is a really high score with these approaches, as we've learned. So that's generally where we stop. So we divide the scores up into bins. We figure out how many notes in our entire cohort fit into each one of those bins for each clinical event. Then we estimate what's called the precision and recall for each interval using silver standards. For the clinically minded folks in the room, precision is positive predictive value, and recall is the same as sensitivity. And in information retrieval, PR is precision and recall PR really the order of the day for a lot of these types of studies. Then we set the marginal error for the estimates in each bin to about 5%. And that's a number it could have been 6%, it could have been 4%, but we chose 5 for our purposes. And that's what we used to come up with how many notes or note days in this case we needed to actually sample from every single score bin. And we did that randomly. And that's what went into our gold standard chart review. The actual chart review was done rigorously and really by the numbers. Again, for those of you who do this work, we first develop a guide, an annotation guide for each clinical event. And when this work is out for publication, we're going to publish those guides too. We conducted training. So we had multiple annotators for each clinical event. We look at around 50 of those chart days in this case. That's that 24-hour period I mentioned for all reviewers. We then sit down and we say, how'd that go? We look at what happened. We look where confusion was. We looked where, things that needed to be refined, and then we iterate and refine. Critical step in really in all science, but certainly in modeling work too. And then when we said, okay, this looks like a reasonable annotation guide, we think we've got our answer. We think we've got our compass here. Let's dig into the full corpus and do the full scale chart review. So we did that next. And we note at the time, the reviewers noted the presence or absence. I mentioned phenotype here, which is frankly, a little confusing because I've been saying clinical event. It's the presence or absence of the clinical event. And specifically, the annotation guide spends a lot of time differentiating whether the event looked like it was something that happened in the past and is being documented today versus a new event for that individual. So we spent a lot of time on that part of it. That was a key step that differentiates this work from what came before. We really wanted to know, did this describe a new discrete clinical event that was detected by this NLP system, that if we did this whole chart level thing, it would have just been blended with all the signal in the rest of the chart. When there was disagreement, that was relatively rare here. We had a third reviewer to do the tie breaks in terms of just defining whether or not the NLP seemed to get it right or not. We're going to evaluate this approach by looking at the performance of the NLP using mirrored metrics that reflect the preliminary analyses that I mentioned in that prior work. So precision and recall and F1 score are going to be important here. We looked at that error by score bin. So we did the actual chart review, and then we calculated what the actual error was to see how close we were. And then we're going to replicate what we're going to try and do. Partly why we did that is because it's a really common challenge. We develop models that tend to be more probabilistic or continuous measures of the likelihood of something. And then sometimes at the end of the day, you have to put your penny down. If you're a clinician deciding, am I going to prescribe something or not? That's a binary decision. I do it or I don't, right? And that might be informed by continuous measures, but that discretization of a decision ends up being a key challenge. Partly why we were thinking so much about score bins is because we know that understanding downstream fully when we're going to put the penny down that yes, it did or it didn't happen, we're not exactly sure how to tune that yet. So that's why we wanted to look at all these score bins and really be thoughtful about how we looked at performance. There's one other piece of it I don't know that I mentioned yet, is that we also want to look at performance by key groups when we start to think about fairness. And you'll see that in the results. I didn't mention it in the methods, but we're going to think about some key groups with a very sort of preliminary look at that, just to get a sense when you're looking at performance. You don't want to just look at aggregate performance these days. I think we've moved past that. We really are starting to think, just in the community, we're starting to think about what groups might be most at risk for unfairness in algorithms like these. And if we can think about those groups up front, do we want to think about measuring performance specifically in those groups so that we don't develop systems that are at scale unfair for anyone in particular? So that's a really big challenge that I'm only going to really scratch the surface on today, but I didn't mention that anywhere else in the methods, and I want to make sure I do before I get to the results. So our baseline cohorts, when we look at those really large longitudinal records that we had available, and I should mention this is certainly IRB approved at our research site. I should mention that explicitly. For the clinical events in question, you'll see phenotype is used here somewhat interchangeably, which isn't perfect, but please go with it for now. We had around 89,000 records that evidence the suicide attempt clinical event, and around 36,000 that evidence the sleep-related behaviors event. The age medians are shown, these are coded variables, coded sex, coded race. Again, speaking to fairness and group definitions, our electronic health record, to their credit, has recently added a feature where people can self-identify gender, a really critical feature we haven't had and we did not have for much of the data sort of collection here over 20 years of care. So that's a really nice advance, but it's just not going to be reflected in these data, which are coded variables from demographic tables. And I am the first person to raise my hand and say those are not a perfect or even a very good definition of how people self-identify. But because that's somewhat standard to report, and because I did want to give you a sense of those breakdowns, I do report them here. When we look at silver standard performance, that first dart at the board that I mentioned, we used ICD codes derived from the literature. With respect to the suicide attempt clinical event, we had a lot of background there. We'd spent a lot of time thinking about that as an issue, and there's a ton of literature on that. So we had code sets that we brought to bear, derived from the literature, to give us a sense of how this system performed using ICD codes. And depending on the version of the ICD that was done, we've actually done that over 2 different studies. It really varied. So moving from version 9 of the International Classification Disease to 10, we saw a real bump, a real improvement in positive predictive value for a code to find a clinical event like a suicide attempt, differentiating, repeat documentation of the same event versus different events. There's some friends of ours, including folks like Dr. Smoller at Mass General, who are doing really wonderful work trying to really differentiate those and deal with codes, a problem for another day. But no, that's partly why you see some big differences in PPVs from one version of ICD to the next. For sleep-related behaviors, we see broadly, there's a much smaller code set there. In the literature, we did not find to be nearly as broad as it is in the space of considering a suicide attempt as a clinical event. That PPV was around 60% with a mix of codes. And we were a little more heavily weighted in the ICD-10 codes there. Now, when we move to the gold standard, critically, when we apply the NLP and we evaluate its performance against chart validation, hand chart validation, we're talking on average around, I think it was 4,000 charts for one of the clinical events based on our power calculations, and a little bit lower for the other one, around 2,000 to 3,000, if I recall. When we compare to a gold standard, we see how our performance plays out for these NLP algorithms. We also see big differences in performance. And that was the key finding and partly why we architected this study the way we did. For the suicide attempt clinical event, the area under the precision recall curve. So that precision recall curve that I mentioned before and shown in our prior slide, if you calculate the area under that curve, a higher number is better. One by one being perfect. A higher AUPRC is better, and we see a reasonably good one for the suicide attempt clinical event. And again, these are discrete clinical events derived from notes within a 24-hour period of notes. So clinically useful, and also we think from a safety surveillance perspective, potentially useful downstream. When we look at sleep-related behaviors, the performance is not as good. The area under the precision recall curve was 0.31. In the discussion, I'm going to hypothesize why that might be there. Note here, there is a performance difference, and we include the confidence intervals. And that's, again, that error calculation that we wanted to do. And we also have a sense of error really across the spectrum of scores, which we think is useful, that I won't report it today. We can look at the precision recall, and we can do that by a variable of coded race, which, again, not a perfect, it's a social construct. There's a lot of really thoughtful, wonderful work happening in the literature right now. I am not going to put forth this work as the exemplar for that study. What I'm trying to show here is that it's important and really critical to look at the performance of any type of algorithm by those group definitions that matter. One that we had close at hand here was coded race, so we used it. And it gives us a sense of how disparate the performance is by group. And so what you can see here is it's more tightly clustered in one clinical event on the left than it is on the right. And that sleep-related behaviors on the right and suicide attempt clinical event on the left. And those differences really matter. So before we would implement something like this, we would want to understand and explain and try to correct these gaps such that we don't have an algorithm that performs disparately for any particular group. That's the take home here, that this evaluation really should be done, really done thoughtfully. Group definition should be done thoughtfully. Again, it becomes its own sort of modeling problem to say, do we have good definitions for these groups that we can find at scale? Really thorny problem to figure out. What I'm trying to do is shine a light on the fact that this exists and this problem exists. So that's what this slide is really hoping to capture for you all, that the performance was not the same across groups, and certainly problematic in sleep-related behavior. So we wouldn't pass go on that one. We would evaluate it further and try to understand these performance differences. Then we start to think a little bit about threshold. So what this kind of approach makes actually much more simple is you have continuous scores where you can think about, if you were going to implement a system like this, where would you set a threshold? What score would prompt someone to say, hey, these might be clinical events we need to investigate versus not? You don't have to set a threshold. It's not necessary, but it is a fairly natural follow-on for a lot of the work that I've talked about so far. And we can do that based on picking an NLP score. And one of the common scores we'll use, the harmonic mean of precision and recall, is called the F1 score. And using that to essentially say, well, at a score of, for example, 25, we'd have an F1 score of 0.75, a recall of 0.9, and precision of 0.6. Necessary to do to understand the algorithm, why it matters moving forward, either clinically or from a population health perspective, it matters because choosing that threshold requires you really to understand what you care about. So if you really care about a high precision approach, you might choose the threshold one way. If you really care about capturing every case, high recall, you might care about something else, and so on and so forth. So that's really critical. It doesn't mean this is the one we'd run with, but it means that choosing that threshold is something that's fairly easy to do once you kind of set up this type of a pipeline. So now let's move into kind of summarizing with discussion, and then we'll have some time for Q&A. And I think I'm just about right where I want to be on time. So we think this kind of approach is feasible. Performance notably differed by phenotype. So it doesn't mean you can just set it, feed it a whole bunch of phenotypes, turn the crank a few times, and have a bunch of algorithms coming out. Taking people out of the loop is not something we want to do just yet in terms of that evaluation. Even with really imperfect coded race variables, performance differences were really identifiable and concerning, certainly for that sleep-related behaviors in particular. So it's something we need to investigate further and really bridge before we would say this is ready for runtime. Third, this concept of something called algorithmal vigilance. The chair of informatics here at biomedical informatics at Vanderbilt, Dr. Enby, has written really nicely about this. It's really the science of preventing algorithms, like any algorithms, from having adverse effects in healthcare. Well, that mantra, that kind of philosophy, it brings to bear here as well. The idea that not just that evaluation, that first validation of an algorithm, but really throughout its life cycle, we need to be thinking about these systems. Because, we found this gap now, but we imagine there may be gaps we didn't detect that once we've implemented a system like this would grow over time. We need systems in place to help us detect those gaps. Just one of many parts of this algorithm of vigilance concept. Those performance differences, so with these clinical events, they differ by how observable they are, how much other clinical data there are to separate them. The quality and degree of documentation in clinical areas varies a lot. The differing event rates at baseline, differing phenomenon based on those groups that we choose are important for understanding those differences, differing rates of coding. And critically, it's, we have to know to ask the question, we have to look. And if we're not sure exactly how to ask that question, we find those collaborators who help guide us. That ends up being a really important step. The implications here, a silver standard ends up being really useful here. And because it relies on generally structured data, data that are really easy to compute, we can use that for sample size calculation as well as for preliminary performance estimates. And as I say here, it's necessary, but not necessarily sufficient. And critically, I've said this a couple of times, that human input was really necessary. And one of the things I like most about the system that, Dr. Bahan architected and we've adapted here as a work group is that it still requires that human in the loop step, even at the query phase. So that query reformulation I described to you, I really like that that's a part of it because it's without that kind of a checkpoint, it's really easy just to let noisy clinical data drive an algorithm's performance. And sometimes it even looks like it performs well, but it may not be for a good reason. It may be because of some artifact in that chart. So where are we going next? Expanding this kind of idea, thinking about how we choose other clinical events or phenotypes here. And again, forgive me for using those a little bit interchangeably. Replicating the pipeline, tackling those performance gaps that we see even in the in the clinical events we've thought about so far. We've looked at one big healthcare setting here, but thinking about new settings and new systems is really important for approaches like this. Testing new algorithms. Try to open just about any website today that might deal with technology and try not to find an article about large language models, ChatGPT and others. They're everywhere for good reason. So testing those types of approaches. When we did most of this work, that groundswell, that inflection point hadn't happened yet. So that's clearly sitting there for us to try. Considering different performance benchmarks, right? So what matters for a clinician making a decision at the point of care is different than what might matter for a population health expert or for someone sitting above, multiple healthcare systems who's worrying about post-market surveillance, for example. Finally, the modeling to design piece, what would a system actually look like informed by this? And again, depends on those things I mentioned already, who's going to use it, where they'll use it, and why, determines that design. But design comes part and parcel with a lot of this work, at least it does in our research program. So happy to take some questions now. Just want to take a moment to let the names of the wonderful folks on the team. And this was a truly multidisciplinary, multi-site, everybody's name. And this is probably it's not probably, it is a non-comprehensive list. I'm sure I missed people and I apologize to those folks I missed. There's lots of different disciplines recommended here. There's lots of different input and everybody listed here had a say in how this work went. And that's a really critical thing I wanted to emphasize. So I might actually let the slides go down right now so I can take some Q&A. And thank you all for your attention. And it leaves us just about, I think, 10 or 15 minutes to chat. So thank you.
Thanks, Dr. Walsh. That was such an interesting presentation, and I think really highlights the variability given your two use cases with such different performance and really understanding and unlocking the keys to why that performance might be different. So we have a couple of questions in the Q&A. One is a very factual question, and I took the liberty because it came in rather early in your talk of looking up the answer because it's a factual answer. So the question that came in was, under the ICD-9 coding system, there was not a requirement to report external cause of injury codes to insurers, and therefore they were under-captured. And the question is that resolved in ICD-10? So not knowing the answer, but figuring it was Googleable, I did a Google search while we were looking, unless you want to go ahead and answer it, because I didn't know for sure, but I did take a look.
I would love for you to comment on it too. If you did something. Yeah,
the answer was that no, there is no federal requirement for external cause of injury codes to be reported. That state by state, there may be individual reporting requirements, but that those are highly variable. And so we can, the equivalent, I should tell folks from the ICD-9 era, external cause of injury codes are E codes. They've become V codes in ICD-10, but they're the same thing.
So this, I'm sorry.
Go ahead.
Oh, no, I just want to add to this. So there's a couple pieces of it. So like in Tennessee, for example, I'm a member of the Tennessee Suicide Prevention Network, which is a wonderful, multi-site, multidisciplinary coalition of folks. Partly one of the things that we talk about in just about every quarterly meeting we have is there's a database called Essence. There's other systems that are out there where, this reporting is encouraged. But again, as you mentioned, it varies. With respect to the codes, so partly why we think we see a big difference is just the way the codes have been designed from 9 to 10. So there are 14,000 ICD-9 diagnostic codes. There are around 65,000 ICD-10 diagnostic codes. That's a big jump in granularity. And one of the things we saw, so we looked at the E codes quite a lot in some early work we did back to, going back to 2016, published in 2017. Those codes, intention is really challenging. So intent ends up being really important. In that first work, I partnered with suicide researchers and psychologists, Joseph Franklin and Jess Ribeiro. They were the chart validators for that study. And one of the things they looked for was non-zero intent to die from an event. And that's what they validated the codes against in looking at nodes. Why that matters is the actual titles in the E codes are fairly broad, and intention is less well specified. And in 10, that did actually get a bit better. So that's part of the reason. The other thing is there's more attention on suicide prevention as a problem, which is great. So there's a lot more attention on getting that coding accurate and people just doing a better job at documenting that kind of thing. That also helped it. There's probably a more nuanced and larger answer to that too, but in interest of time, I'll leave it at that. But I'd be happy to follow up with whoever might have asked about that particular question.
That was the PI of the Innovation Center, who I'm sure you know very well. So
Yeah.
you can follow up with him at your leisure.
Very good.
So the next question comes from the FDA, asking about if you could expand and explain a little bit more about how the silver standard is used to inform the sample size calculation for the gold standard. If you could maybe walk through that one more time, that would be helpful.
I can tell you exactly. So you imagine you turn the flywheel in the system, and you can generate scores from the methods that I described: the query step, the reformulation, that generating that phenotypic profile, and then applying those vectors. One of the first ways you can estimate a score is if you have a standard that's structured data that doesn't require hand review. That's in this case with silver. For a diagnostic code set, one of the things in a phenotypic selection or clinical event selection, if you have that set and you're using, it doesn't have to be ICD codes, right? It might be something else. It might be a presence of a test is a really good marker that something's present. It doesn't have to be a code. We just use those here. Anything that's structured that's fairly easy to grab becomes your 0 or 1, your dependent variable for that first step. So when you have scores, the scores themselves, and you have the zeros and ones next to each other, you can bin the scores, rank them, slice them in whatever bins you care about, and then the numbers of zeros and ones in each bin can drive your preliminary performance. When you set an error around those scores to say, hey, this is the marginal error we're targeting, how many charts would I need to look at to essentially, in a gold standard step, be able to say, this is how it really performs with this band of error? Essentially, that preliminary score, through some calculation done by our statistician, Dr. Cindy Chen on this one, that calculation allowed us to pick, we had essentially, for each score bin, we had an N of charts that we pulled out. We spent quite a bit of time on that, actually, in terms of what we cared about and what metric we were going to use to power it. And I'm happy to share more details offline with whoever's interested. But now it's much closer to, a reproduce. That part is pretty replicable, actually. That's not something I'm worried about, as far as running it, because that step is pretty reproducible. The decisions to be made are certainly what's the clinical event, 2, what's your silver standard measure that's structured and easy to get, and then what error are you seeking? Those are kind of the key inputs for that one.
So thanks for that answer. The next question relates to the cost effectiveness of this method as we move forward in time. So we talked a lot right now just about how 9 codes change 10 codes. So validations done in a 9 era are not necessarily applicable to a 10 era. And we saw that big jump in precision, particularly in suicide ideation. So this requester is asking how often that has to be done as clinical practice, proceeds, and is it cost effective as a process to repeat this through time?
And to make sure, is it repeating the validation step specifically, or might it be retraining or updating an algorithm that works in this space, or both?
It's the idea that there's a need for continuous validation to make sure that we're keeping up with changes in clinical practice.
Right. Great question. So there is a large body of work that I've been more peripherally involved in. So any algorithm, for example, is at risk of something called drift. So the rate of an outcome, an incident, for example, changes over time. The features that might go into an algorithm change over time. And we've done a number of studies outside this space where we've seen, for example, documentation rates have changed. I talked about ICD coding change for a problem like suicide attempt over time. We had well, I'll skip the example in the interest of time. Documentation evolves over time. So one of the folks on our at Vanderbilt Biomedical Informatics named Dr. Sharon Davis, working with running her own research program, working a lot with Dr. Michael Matheny, who's one of our work group members here. So she's got really industry leading, to my mind, methods for drift detection. And those methods, once you have diagnostics in place, algorithmically tracking these things over time ends up being, the install, there's obviously an investment to install these types of systems. A piece of that surveillance of the system over time, we think is algorithmic. We also, and having conversations with Dr. Emby, who I mentioned, and other folks on teams and other related and unrelated work, automating systems or designing systems that are semi-automated that really track the detection to focus energy, because you can't hand review every single one, right? That's not cost effective. So systems that help shine the light where the car keys might be, pointing the spotlight where the car keys might be, as opposed to, where the light is now, and that's not where you drop them. That's why we think algorithms play a role there. That ends up being a more marginal expense. Like anything, person time is one of the key expenses there. How often we revalidate or would pull another set, we haven't gotten there yet. We haven't thought about that. We have thought quite a bit about how often you would retrain a model as these things change. And there's actually a lot of levity, moving toward this mantra, this idea of a learning health system, the idea that these algorithms are something that could also retrain and be improved over time. Now the standard, if it's done at all, because it's not always done, is that's done in a batched way, at points in time. The idea of doing that more continuously is enticing. Cost effectiveness ends up being an important kind of an underpinning here. So it's the person time. The algorithmic approach to target that person attention is one cost saving measure, but we haven't done all the work to really give you a good answer or an estimate of what this system might cost. But I'm a big fan of those types of studies, so I really appreciate that question.
Great. So one of the requesters asks particularly and points out that some of the large language models and other types of these newer models that are available can incorporate image data into their input set. And then that helps their prediction purpose. Have you thought about exploring incorporating image data into some of your current and maybe particularly sleep-related behaviors, suicide? I don't know if those particular outcomes might benefit more or less from image with things like X-rays and that sort of stuff. But is there a planned mechanism to start to incorporate imaging of any sort? Let's think of it as a general sort of topic, something that is a non-text component into these types of models.
No, I love it. I love that question, and the idea I love as well. And so we have had multiple conversations about image data, not just in this context, but in others. And even before the LLMs were sort of the big order of the day, there are folks at Vanderbilt, for example, Dr. Daniel Fabry, working with Dr. David Kent, partly a few years ago, looking at EEG. Can we take EEG signal, those strips, and can we automate an assessment? And can we do that as well as a person might do? For example, thinking about various problems that might be diagnosed related to it. It's very clear. I've got a couple of other unrelated projects where multimodal data, just like that, imaging plus text, plus codes, plus something else. Multimodal data are really powerful. Very hot topic. It's pretty clear, I hypothesize pretty strongly, including a stream of data like imaging data will improve these methods. There are various studies we could think about, and there's work pre and post LLMs in integrating these data. The interesting part about LLMs, and I haven't done the work to justify the statement yet, is does it make it more easy? Like, is it easier to move into that space, easy kind of in quotes there, to integrate different types of data because of how flexible those models are? And that's something that was a little more kind of hand keyed in the past. But that as an idea has been around for a while. There's also already great work in that space. We have very squarely talked about integrating it. We haven't done it yet, but it's a really great subject for a future study.
Thanks, Dr. Walsh. So one of the questions here is, and I'm going to read sort of exactly what they've said in certain aspects. I've seen manuscripts that argue that they can use NLP to detect events such as certain conditions in the pathway to cancer in a large data set without, with emphasis on without, human interaction of vetting the quality of the algorithm. Can you comment on your agreement with that statement?
I like that question a lot. So to my mind, I don't think our results today suggest we should proceed without some level of human validation. Deciding how much you need is a question. So there are studies like this where people look at 1 to 200 charts. In a study like ours, we looked at 4,000. It takes time. It wasn't actually cost prohibitive to do that. We had 2 really good annotators who did that over the course of a few weeks, and for a really feasible cost. So it's not out of the question. I think the decision to whether or not it can be done relates to how confident you are that your standard that doesn't require human validation is accurate. So I hope I didn't garble that too badly. So if you think you have a really good silver standard, it looks more like a gold standard, you might be willing to trust that method going forward. What I would strongly recommend is just think about the uncertainty quantification there. And there's a few methods out there in terms of how you might do that, but just try to get a sense of how wide the confidence intervals could be on performance if you're going to go fully structured. I think what we've tried to show here is that generally speaking, that human piece is reassuring for us in terms of how the performance works. And we saw some differences moving from silver to gold. So it is going to be phenotype dependent. It's going to be setting dependent, and it's going to be confidence dependent.
Thanks. I think there might be a follow-up question because I see an individual raising their hand. I'd encourage you to go ahead and put that follow-up question if it exists in the Q&A so we can read it out for Dr. Walsh to answer. In the meantime, I'll take the liberty, since we've got most of the questions answered that have been asked so far, to ask a question of my own, which is, so Dr. Walsh, you talked about the importance of negation as a component of the just processing of the note. And here I know you're looking for incidents. And so you really want to understand that it's a new event. It's the first occurrence in a certain period of time. Do you know of, or are there common procedures to remove things like history of blah, 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 or I had this thing that happened a month ago, where there's some clue in the actual text that it is not the first that has happened in some period of time that could be applied in a similar way to negation, that a negation algorithm, where you're deliberately trying to pull those things and remove them from your note set?
There is extensive work in this space over decades of time. Natural language processing has been around for a long time, well before I entered the field of informatics. And I do not consider myself a card-carrying NLP person. That's not my discipline. So I'm going to be really cautious about overstating. But even so, in informatics, as an informatics fellow at Columbia, reading about MEDX and NEGX, so algorithms that essentially are intended to pull medications out of notes, to pull negation out of notes, to pull temporality out of notes. So for those of you interested in this with an informatics leaning, AMIA, our big informatics conference that happens every November, invariably there's a dozen or more really great talks about really exciting techniques exactly in that direction. So yes, breaking apart phraseology, a month ago and capturing that. Every year I see talks about that. There's a lot of work in that space, and I would encourage the person asking, I would encourage anybody interested in that to do some reading on it, and I'm happy to kind of help get people started. It's a really rich discipline.
So, Dr. Walsh, I think I'll ask you one more question, since I'm not seeing anything else in the Q&A space here, and then we'll go ahead and close this session. So some of your other colleagues, who I know you are well aware of, are working in the natural language processing field, and they are using, rather than a keyword starting point, they are feeding journal articles to essentially be the keywords. Can you comment on the compare and contrast in that, in terms of human effort required to pick out those articles? Do they perform better? Do you think the keywords perform better? What would be your thought about how to put those kinds of multiple ways of sending inputs to the initial, to seed the model into perspective?
What I think about is ensembling the signals. I think take just about any clinical decision, and read the literature on the guidelines, read the literature on what a trial might say for what somebody should do. And then empirically look in real healthcare records, what people actually do. Both end up being important. And sometimes, sometimes there's no, so Dr. Jonathan Chen is somebody I know from Stanford, wisdom of the crowds, this idea that, well, maybe there's not a guideline for something. So we have nothing but our healthcare records to look at, and not trying to put words in anybody's mouth. But I really like that idea. Sometimes it's just in there because we're getting the healthcare work done, that healthcare delivery. Augmenting that kind of signal, and our work is using those real healthcare records because that's where we're applying this method. Augmenting that signal with literature-based definitions, I think, would be a boon. You could do the bake-off, right? You could compare method A to method B, and you could also put them together. And generally, when we've put those kinds of things together, usually the combination's better than either one alone. I can't think of an easy example where that wasn't true, and I suspect that's true here. So as far as the effort part, I don't do a lot of the literature, derived algorithmic development. So that part I'm a little hesitant to comment much on. We certainly do a lot of literature review, and we did a bunch here because just to find the ICD codes, we had to review literature we weren't naturally familiar with clinically because only one person in our group was a sleep expert. So so that part I'll hesitate to ask about, but I really like the idea of combining them.
Thanks for that answer. So folks, we're about out of time. So I'm going to once again thank Dr. Walsh for presenting today's webinar. As a reminder, this session has been recorded and it will be made available on the Sentinel webpage along with the slides. You can also find the details and the registration links for future Innovation Center and Methods seminars on the website. So that's www.sentinelinitiative.org. And this concludes our session. We really hope that we see you next time again. And thank you, Dr. Walsh. It was very wonderful talking with you this afternoon.